Hello and welcome to EJC News Focus. The heterogeneous nature of cancers has long been a stumbling block to successful treatment. But delegates at the European Cancer Congress in Vienna heard that the most heterogeneous cancers might just be the ones to respond best to immunotherapy. Caroline Robert from the IGR in Paris made the comments in the opening plenary session. I met her and asked her to explain. So, Caroline, where are we now with immunotherapy?
So we're at a very strategic turn, very radical turn, I would say, because it's a long time we try to treat patients with their own immune system. It's a very nice idea to defend ourselves with our own immune system, but until now it was not really possible, it was not really easy. And with the new checkpoint inhibitor for these recent years, on melanoma we made a huge step forward. So we know now that we can, when we evaluate the patient with the normal tools of oncology, we have treatments with anti-CTLA-4 for some years and now anti-PD-1, even much more effective, that are really changing and that are really prolonging the life of our patients. So right now it's a really strategic time, and plus the melanoma, it was advanced melanoma, it was really one of the worst cancer to treat with classical agents, and now it became the cancer with the most promising therapeutic, with combined targeted agents, immunotherapy that now we are going to combine. So it's really a very important period.
How do you see it developing in future?
So first, it doesn't work only for melanoma. These new immunotherapies, now especially anti-PD-1 monoclonal antibody, they are now evaluated in more than 30 different cancers with sometimes very good results, like for example with Hodgkin lymphoma. We begin to think of combining with anti-CTLA-4, and also what is very important is that now the field of the genomics and the field of immunotherapy are going to work together, because it has been demonstrated that the tumors with the highest mutation load, the somatic mutation, which is a hallmark of cancer, and especially some cancers like melanoma because of the sun, or lung cancer because of the cigarette smoke. These cancers which have a high mutation rate, they are the ones that might respond the best to immunotherapy. Why? Because at the favor of this mutation, they can sometimes give rise to neoantigens that are going to be presented to the immune system, and because we release the brake of the immune system, we unleash the immune system, then these bad cancers, they might be the best responders to immunotherapy. So now we begin to have programs all over the world to sequence the somatic mutations in the tumor, to predict the neoantigens that are going to be potentially presented to the immune system, and you imagine all the new options that we have now in our future, all the possibilities, because we can imagine to increase the presence of this neoantigen. We can use a lot of new technologies, but the most important, I think, and this is what I said in the opening session of this meeting, is that now we are all going to work together. There are not the people who think only of immunotherapy and who don't look at the mutation, or the patient who think only of targeted therapy and don't believe in immunotherapy. Now everybody is going to work together, and we will need to have a lot of good bioinformatic background, because we will generate a lot of data, and it has to be analyzed with smart people.
So I think you said that the future lies in combination and sequencing.
Yeah, we will probably, we are all convinced that we will have to use a combination of therapeutics, or maybe sequencing treatments, because we also know that a lot of therapy that we use, which are not primarily immunotherapy, in fact, they act on the immune system. They sort of remodel the immune landscape of the tumor, which is very complex. They act on the cells that are on the sites, not only the T cells, but also there are a lot of immune cells that also are important. Myeloid-derived cells, there are macrophages, there are B cells, there are follicular T helper cells. A lot of cells are important. And plus the receptors like PD-L1 receptors or PD-1 or others that now are discovered like LAG3, TIM3, CD40, that can be modified by the action of some chemotherapy, some radiotherapy, some targeted agents. So it brings a lot of new opportunity to study that and to try to combine the best.
So all sorts of conventional treatments may in fact be immunotherapy?
Exactly. It is the case. You use drugs that primarily you don't think are immunotherapeutic agents, and finally they act on the immune system. Yeah.
How long do you think it'll be before there's real progress in that 50% who don't respond?
So who would have predicted that we would be there now if you just look like 7 years ago? Nobody. Who would have predicted the efficacy of just anti-PD-1 monoclonal antibody? So, I mean, it's our job to be optimistic. So I think probably in a few years we will begin to, as you say, to begin to have an effect on these 50% of patients who right now do not respond to anything.
And with thanks to Caroline Robert, that's it for this month's EJC News Focus.